All right. Okay, I think we can start now. Assalamualaikum and very good afternoon to all. This is actually welcome to our third MAPD webinar. We have lined up 11 webinars up to until December 2020. So for those who recently joined us, this is actually our third webinar. So we still have 8 more webinars to go after this. All right. I would like to invite all to like and share our MAPD Facebook and Instagram page, where you can get more information of our future webinars and also information on the pediatric dentistry. Before we start, I have 2 housekeeping announcements. The first one is that we will provide the link for the CPD points at the comment section at the end of our webinar. So kindly stay on for our webinar so that you can claim for your CPD points. Second announcement is that if you have any question or queries for this webinar, kindly put in the comment section so we can address your question during the Q&A session, tentatively planned around 12:45 or 12:50 later. All right. Before we start, I would like to introduce our speaker for today. Dr. Muhammad Yusmi Aidil Putra Muhammad Yusof. He is an associate professor at Faculty of Dentistry, University of Malaya. He is a very good friend of mine. Sekarang ni semua member-member saya je jadi member tiba-tiba. He had his Bachelor of Dental Surgery from Faculty of Dentistry, University of Malaya, and he had both his Master in Forensic Odontology and postgraduate diploma in advanced medical imaging from KU Leuven, Belgium. In 2016, he successfully defended his PhD doctorate on dental age estimation models in children and sub-adults from Ghent University, also from Belgium. He had many posts before this, for example, like head of Center for Oral and Maxillofacial Diagnostic Medicine Studies. He is currently the Principal Research Fellow at Institute of Pathology, Laboratory and Forensic Medicine at Center of, is actually a Center of Excellence in UiTM. Dr. Yusmi Aidil has been involved in a few forensic investigation. If I can name a few, one is in the forensic identification of Ops Ma'had Tahfiz in 2017. And also the Ops T-Auraki for exhumation, identification and repatriation of the New Zealand soldiers died during the World War II at Terendak military camp in Malacca. On a personal note, Dr. Yusmi Aidil sebenarnya telah berkahwin 3 orang anak. Dia lag sikit tu. Sepatutnya koma tu dekat 3 orang anak, dia 3 okay. Berkahwin 1, 3 orang anak jangan tertukar minta maaf saja gurau Yus. Baik, without further ado, I would like to welcome and invite Dr. Yusmi Aidil for your presentation. The floor is all yours. Thank you.
All right, thank you so much, Dr. Faisal, for that kind introduction. I'm not sure that whether I've given that extra information, but yeah, I think that maybe just slip, to your hand, something. So, right, a very good friend of mine, Dr. Ahmad Faisal. So, thank you so much for inviting me to this webinar series hosted by the MAPD. Well, I have to congratulate MAPD for this wonderful event. You know, you managed to get the webinar series in 2 weeks' time. You know, within the fortnightly. Well, and then I think that you have a lot of great speakers as well. All right, and then thank you so much for inviting me as well. I'm not a pediatric dentistry specialist, but I'm a forensic odontologist, all right? But I do believe that in interdisciplinary, right? So because I think that whether you are a specialist, whether you are a dentist, whether you are a junior dentist, sometimes that we cannot know everything. So we have to have our friends to support us in terms of their specialty. And by that sense that I think that we have to know our limitation as well. All right. Okay. So today I'm going to talk about incriminating dental trauma in children, sign and symptom of abuse. In other words, I'm going to talk about the child abuse and how we want to detect it, because actually that as a as a pit specialist, as a dental officer, you are the frontliners. You are the first one who's going to see these kind of patients. All right. So basically, that you have to have some inquisitive mind in terms of the when you're looking into these kind of patients, right? Because you have to always be suspicious, you know, of certain things like abuse, because actually that you are among the first few people who's going to see this firsthand. So it is your responsibility as well that to prevent child abuse from happening, right? So you are actually the savior for this poor child, right? So actually now that the questions of the hour, that actually that as a dental team members, how certain are you to treat dental injuries as accidental injury, right? Because usually that when we get dental trauma, sometimes that we are treating them as most of the time that we are treating them as accidental injury. So we are going to put a spleen and then so on and so forth, all right? But the thing is, I think that I hope that this talk is going to inspire some of you, if not all, to look about more things that patients presenting to you. All right. So now that I think that the question is, you have to ask yourself that would you or your team members recognize the signs and symptoms of abuse? Would you know how best to record any suspicions? And would you know what action to take in case of suspected abuse? All right. So these are the things that that lingers around in my mind when I wanted to do this talk. Yeah. All right, so the gist of the presentation, I'm going to divide it into 4R. All right, the first one is responsibility. All right, recognizing, responding, and reorganizing. So this is actually the way forward for us to manage child abuse cases. All right. So for responsibility, I'm going to talk about the child protection and whose responsibility it is. I mean that we are going to look into. I mean that there are so many walks of life and people that going who are going responsible for this.
That I use me
Yes.
ideal. If I can interrupt, some are asking because they cannot clearly hear your voice.
Oh, all right, all right. So I have
Thank
to get
you.
more closer. Can you hear me now, Dr. Faisal? Can I
I,
get
I, I,
the
I
validation?
yeah, yes.
All right then. Okay. I hope that everyone can hear me now. All right. And secondly, I'm going to talk about some risk factors as well within the responsibility. And thirdly, family and environmental factors. Okay. In recognizing, so we are going to look into the multifaceted physical abuse. I mean, in terms of the type of physical abuse and so on and so forth. And for responding, history and examination. All right, so basically that we are going to look into how history and examination is going to take place and what kind of the questions that you ask the child or the parents or the caretakers specifically. All right. And reorganizing, I'm sorry, the second one is forensic aspect of the responding and how you want to look into the forensic aspect. And I'm going to tell you a bit about bite marks as well there. And reorganizing that I'm going to give you some tips for best practice when it comes to the child abuse cases, or if you suspect if it is actually child abuse. All right, so I'll give you some shocking facts according to the literature reviews, according to the case report that has been there, because actually it's quite a lot. If you just type in or looking into the child abuse, a physically abused child. Right, the odds of a physically abused child having bruises to the left ears, cheeks, and neck to be significantly more than those in a control group. So this is actually from a study from Kemp and Kemp et al. 2014, based on the cohort study of 506 children aged 0 to 6 years. All right, so if we are looking into this based on the left ear, all right, so basically that because actually that usually that we are on the right-handers. So basically that the adults with right-handers will usually abuse a child, by slapping the child and everything. So, and then the left part is going to be affected. All right, and oral findings may have been overlooked with only a single case of torn labial freedom reported within 230 cases of physically abused children. All right, so basically like this is actually in a way that saying that whether we are doing enough as a dentist, as a frontliners, whether we check it, because actually that out of 230 cases of physically abused children, only a single case of labial freedom tear, because we know for a fact that if the child have a labial freedom tear, so we have to suspect of the child abuse, all right? Because actually labial freedom tear cannot just tear like that. It has to be come from a heavy blow or some other external forces. All right, and then bruises to the face, forehead, and ear made up 41 of the 66 total sentinel injuries in the abuse confirmed group. All right, so this is by sheets that's all 2013. All right, so just for those of you who are still a junior and dentist, so basically the sentinel injuries is actually the previous injuries that you may have seen or may have overlooked that could be lead to the abuse. All right. So, for example, like the cigarette burns, sometimes that people overlook this. All right. So they are looking into just teeth. All right. So these are the sentinel injuries that may have occurred. But it is really up to us to pick up that. All right. So now we move on to responsibility. Who is responsible for this for child protection? All right. So of course that. It's everyone's responsibility, and it is also a shared responsibility and the responsibility of every member of the dental team. All right, so not just the dental surgeon, not just the DSA, but also a person at the counter as well. All right, so now everyone's responsibility. It is a responsibility shared by all members of society, all right? Because we know for a fact that children is considered as a vulnerable group, all right? So we must, caretakers, we must have parents that take care of the child, all right? So we cannot just stay silent anymore. I mean, that if anything happens to the child, for example, like if you are seeing child being mutilated, or child being screamed at at the public. So basically that you have to be a good citizen. You have to you cannot just ignore that fact, right? And then a shared responsibility, it is a responsibility shared by many different groups of professionals, and decisions about children are never taken by one individual, but always shared by effective inter-agency working and team discussion, all right? So basically that when we want to decide that whether this is actually a child abuse case, it's not just based on just one person, all right? So it has to be an interdisciplinary decision, all right? Because actually that for dental pit specialist or dental pits officer, basically you are the first one to see this, but you must have a second opinion from other people, especially from forensics or pediatrics as well. All right, responsibility of every member of the dental team. All right, so this is include who may observe signs of child abuse and neglect, or hear something that causes them concern about the child, who are not responsible for making a diagnosis for child abuse or neglect, but must share concerns appropriately, and who all share the responsibility. It is not just the dentist's responsibility, and who may not treat children themselves, but if they treat adults who are parents, they too need to be aware of these issues. All right. So basically, that just now what I mentioned, actually, the whole dental team is responsible for that. All right. So including the persons at the counter as well, because actually that this person could pick up some abusive language or abusive behavior comes from the caretakers. So basically that they have the right to say something as well. All right, risk factors. All right, so this is important because actually that when a child comes to you, basically that you have to look at this risk factor, because actually that for a normal child, the likelihood of getting abuse is quite low. But if there is any additional factors such as these risk factors, is going to make the risk of being abused higher. All right, first one is the child was born prematurely. All right, so sometimes that patient with GDD, for example, All right, so because this kind of person, this kind of children cannot take care of themselves. So basically, as a caretaker, as a parent, sometimes that it is quite a burden, or quite a heavy responsibility for them to bear. So basically, that in terms of the patients and everything, sometimes they may lose it. All right, so basically, that the children is going to pay the price. All right, the child has disabilities or abnormalities. All right, so this is something that we see quite a lot. You know, for example, children with autism. All right, the children who cannot listen to orders. All right, so basically these are the risk factors for the children to be abused. The child exhibits certain behavior problems, non-biological relationship to the caretaker. So this is something that we see quite a lot in Western culture, where that for example, like mother got divorced, and then have a boyfriend. So boyfriends become the abuser. So basically, that these are the concerns for the risk factors. All right, so one or multiple births, for example, like having many siblings, okay, that could lead to the risk factors as well. And of course, last but not least, the medical fragility in terms of the medical problem that the individual has. All right, so family and environmental factors. All right, so this is something that we are looking into the family as a unit. All right, violence in the home, in particular, the father abuses the mother, or siblings abuse one another. There are a lot of instances that we see that parents or caretaker who are having substance issues, doing alcohol, doing drugs. So basically, these are the things that could lead to the child abuse. Parents or caretakers lack the necessary maturity to care for the child. All right, for example, like the young parents, without any proper income, and then these are basically the seed to child abuse. Parental expectations and inconsistent with the child's developmental abilities. Caretaker is socially isolated. All right, so no external support system. All right, so they just live in their own land. All right. All right. So basically, these are the family and environmental factors that we have to look at. All right. And another thing is unwanted pregnancy. All right. So basically, in our culture, that basically this could not be one of the factors for the child abuse, but in Western culture, in Western lifestyle, maybe that this is actually one of the big factors as well. All right, high local unemployment rates. All right, so basically, this is actually pertinent to us as well, especially during the COVID-19, where everybody got quarantined, the MCO, and if you read the news, actually, that the domestic violence is actually getting high during the MCO period. All right, so this could happen for the child abuse as well. All right, criminal history of the parents, the mental health history, lone parenthood, and ego defects, where the low self-esteem and inability to empathize. So basically, this is actually happened to young parents. Sometimes that they have low self-esteem because of so many things. So these are actually from the family factors. All right, so next, the second R is actually recognizing. So how we want to recognize the child abuse case. All right, so by definition, all right, so according to the Bouchard et al. 2006, physical abuse is defined as the intentional use of physical force against a child that results in or has a high likelihood of resulting in harm for the child's health, survival, development, or dignity. This includes hitting, beating, kicking, shaking, biting, strangling, scalding, burning, poisoning, and suffocating. All right, so this is the definition of physical abuse. I know for a fact that actually there are a lot of other abuse, such as mental abuse, sexual abuse, but that's not going to be covered here, because I think that we only have like 40-50 minutes. So I'm going to just talk about the physical abuse in this particular webinar series. All right, so some important notes about the physical abuse. Okay, so orofacial trauma occurs in at least 50% of children diagnosed with physical abuse. And then it is always important to remember that a child with one injury may have further injuries. Right, so these are the sentinel injuries that I've mentioned. Right, so always look for any sentinel injuries. You know, if you got patient presents with tooth fracture, for example, always look for some other sentinel injuries that you can find. You know, if you don't, then it's okay. All right, but at least that you look for it and then you ask, parents' history and everything. So that's the best practice. All right, so it is important to state that there are no injuries which are pathognomonic of child abuse, although some injuries or patterns of injury will be highly suggestive of it. All right, so these are the things that we as a frontliners have to remember and to take notes there. All right, again, on the physical abuse and on the assessment of it. So what we have to do is we have to evaluate the injury itself, its extent, site, and any particular patterns, right? Because actually that if you are looking into the orofacial injury, for example, that you see some contusion, for example, right? So you have to look into the extent of it, the site of it, and how big is the dimension of that contusion. Because sometimes that contusion that has been there for some times, it looks like a bruising, right? But the thing is, it could be like the latent bite mark, for example, right? So these are the things that you have to take into consideration. Taking a history to understand how and why the injury occurred and whether the findings match the story given, all right? So when you see something, when you see some bruising, when you see some burns, some marks, so basically you always have to ask what happened. All right. So when you see that, when you asking that, so basically you have to match that whether the story is tally with the physical evidence that you see. All right. So because actually that as a practitioner, as a clinician, we know for a fact that if the findings does not match the story, all right. Exploring the broader picture. All right, so for example, like the children's behavior, the parent-child interaction, underlying risk factors. So these are all the body language that you have to observe. All right, so it's not just the dental trauma, but these are the things that we as frontliners have to look at. All right, so this is not necessarily that something that you ask, but this is something that you observe. All right, so you have to look into that as well. All right, so this is actually a statement from the American Professional Society of the Abuse of Children. It says that the APSAC supports the American Academy of Pediatrics updated policy calling on parents to end spanking as a form of discipline. All right, so when I see this statement, so basically I'm thinking that, well, actually that this has to be based on culture, because actually that for Southeast Asia, for example, that we in Southeast Asia, usually that our parents use spanking as one of the punishment, right? But the thing is, if you do that, for example, like in Scandinavian countries, for example, that you might be jailed for that, all right? So you have to be careful. And then, in terms of that, why I put this statement is actually that this kind of form of discipline, well, actually that it is culture oriented, all right? So in our culture, basically that I don't think that spanking is actually too heavy, right? But for Western, I think that that's something like a no, right? So that's something that we have to ponder, right? All right, so physical abuse, the consequences of physical abuse, encouraging the child to lie, because the children who are getting physical abuse all the time, so basically that they will learn how to survive that abuse, all right? So by having to survive that abuse, they have to lie, they have to live in fear, they have to, insult instead of loving, trusting, and listening. All right. So these are the kind of person that we do not want to create, or we do not want to have, because actually if we are having a physical abuse, basically it's going to get a vicious cycle, because actually the child, the abused child is going to repeat that particular cycle because they thought that that's a norm. Right, so basically that this is something that, you know, as frontliners, as healthcare workers, that we have the obligation to stop this cycle. Right, and then it's going to alienate the child from the family members and make them a recluse. Right, and of course, by, you know, having a child abuse, you know, for so long, it's going to lower the child self-esteem, so they are not able to socialize with friends, and that's going to make their life so miserable in school. All right, so we do not want to have that. All right, carrying on the family tradition, vicious cycle. All right, and excluding parents or caretaker from their adult life. So basically, these are the things that they will do when they go into the adult life. So they are going to exclude everything, exclude the parents, exclude the siblings. All right, because actually that because of low self-esteem and so on and so forth. All right, so now we are looking into the physical abuse, of the types of injury that we usually see in child abuse cases. All right, the first one, of course, that we are going to look into the bruising pattern, the burns pattern, the bite marks, eye injuries, bone fractures, abrasions, and lacerations, and intraoral injuries. All right, so these are the things that we are going to look at. All right, first of all, I'm going to show that some typical features of accidental injuries. All right, so if it is accidental injuries, usually that's going to occur at the prominent bone or the body that the child have. For example, like the head injuries tend to involve the parietal bone, occiput, and forehead. All right, and then elbows as well. So these are the typical features or the sites of accidental injuries. All right, so we have to remember that accidental injuries typically involve bony prominences. Okay, it's going to match with the story. All right, so sometimes that we ask that, okay, why you have a bruising at your elbow? Or because I fell down. So basically that could be the story given by the children. All right, so and then if it's going to match with the story, then it's well and fine. All right, so this is the site for the typical features of non-accidental injuries, NAI. All right, so what I wanted to show you is actually that there is one term that we call the triangle of safety. All right, so this triangle of safety actually comes from the ears, side of ears, side of face and neck, top of shoulders. All right, so this is actually the triangle that usually that you do not see in any accidental injuries, because this triangle of safety is quite hidden, you know, because actually that if someone fall, for example, they are going to knock the head or perhaps knock the shoulders, but not within the triangle of safety. All right, but if you see any bruising or any injury within this triangle of safety, then you have to be very cautious. You have to be very suspicious as well, because actually that could actually one of the indication that the child's being abused. All right, and other thing, the inner aspects of arms, back and side of trunk, except directly over the bony spine, any groin or genital injury, okay, inner aspect of thighs. All right, so this is actually something that we see children having bruising at this particular part. Right, usually that in our culture, because of, you know, they got pinched by the parents or by the siblings. All right, so be careful on this particular side as well. The forearms when raised to protect self, chest and abdomen, soft tissue and cheeks, intraoral injuries, and black eyes, especially if it is bilateral. All right, so if it's unilateral, then you can match with the story. But if it is bilateral, you have to, you know, raise some concern. All right, what to look for? All right, so of course that the first thing that we have to look for is the child's age. All right, because actually that there are actually some discrepancies between the injuries that ambulatory child has and non-ambulatory child has. All right, so basically, for example, babies who are still cannot walk. Basically, that there are certain injuries that could be impossible to get from these particular babies. All right, so developmental level, the sentinel injuries, the previous injuries that have been happened before. All right, location of the bruising. All right, so you can see that if it's happened in the triangle of safety, or whether it's at the medial part of the thigh. All right, size of the bruising. All right, so this is something that you have to look at as well, because actually that if we are looking into bruising that actually within less than 3 cm, for example, well, that could be the bite marks. All right, so if it's more, then it could be some blow from other bigger external factors. All right, the size of the bruising, consistency of history with injury, and the medical history. So these are actually something that we have to look for. All right, so bruising, the first one that we are going to discuss on bruising. All right, accidental falls rarely cause bruises to the soft tissue of the cheek, but instead tend to involve the skin overlying bone prominences such as the forehead and cheekbone. All right, so that's something that's happened now, that because the cheeks actually it's not going to just bruise just like that, because of accidental falls. Right, so it has to be some external forces that could bruise that particular part. All right, inflicted bruises may occur at typical sites or fit recognizable patterns. Bruising in babies or children who are not independently mobile are a cause for concern. Right, so for example, like a baby who still cannot walk, the non-ambulatory child suddenly that have some bruising at the forehead, for example. Well, that's something that you have to have a red flag on that. You have to raise a red flag on that. All right, multiple bruises in clusters or of uniform shape are suggestive of physical abuse and may occur with older injuries. And last but not least, but I think that this is important, the clinical dating of bruises according to color is inaccurate. Because actually that sometimes that we do that in clinical setting. Sometimes that we look at the bruising, we say that, oh, it's still red, so which means that it's new. All right, so it has been turned into purple. So basically that disease has been there for like 2 days already. So basically that the clinical dating of bruises is inaccurate. So we cannot do that. We cannot say the dating of the bruises based on the colors. It's just inaccurate. All right, so I guess that this is actually a famous line in pediatric, in forensic pediatric, because they say that if you don't bruise, you don't bruise. So which means that if the child cannot walk, so basically they cannot bruise because of the fall or because of other things, all right? So if they still in baby phase, they still cannot walk, basically that is difficult or actually impossible for them to get bruised. If they have gotten any bruises, so basically that you have to raise a red flag on that one as well. All right, so this is actually that what happened when a young child has been gripped and force fed. You can see that some petechia over there with some digital imprints. All right, you can see that the thumb print there, and then as well as the index finger print, and so on and so forth over there. All right, so this is actually that the bruising that you can see that when the child has been clipped, and then if they are being force fed, so basically that you will see all the petechia, all the imprints at the cheek of that baby or children. All right, we'll move on to the burns. All right, approximately 10% of physical abuse cases involve burns. All right, burns to the oral mucosa can be the results of forced injection or hot or caustic fluids in young children. All right, so cigarette burns is actually that one of the landmark of child abuse. All right, so it can result in circular punch-out lesion of uniform size. It looks very oval and circular shape. All right, this is actually the example of the burn at the triangle of safety. All right, so these are just happened underneath the ear. All right, so at the triangle of safety. So when we see something like this, so we have to be very, very cautious, and we have to ask the right questions. We have to match that story given to the burns of to the injury that we see. All right, so this is an example of the cigarette burns. All right, you can see that it looks very perfect circle. All right, so basically that if it is pathologies, some others, pathologies, for example, that well, it's not going to look as circular as this, all right? So when you see something like this, especially that in the multiple spot, so you have to have some minds as well that it could be a child abuse case. All right, so now that we are going to talk about the bite marks, all right, so bite marks is actually that happens quite a lot in children, because sometimes that you have to, because when we see bite marks, sometimes that it's not just a standard bite mark, just one single bite mark. Sometimes that you have overlapping of bite marks, all right? So basically that if you have like one single bite marks with a good indentation, well, I think that's a good, that's a good case. That's a perfect case to work on. But the thing is, it's not usually happen like that. Sometimes, most of the time that patients will come to you with multiple bite marks, overlapping bite marks. So that's going to be very, very difficult to work on. Well, I think that in that particular sense that, you have to refer that to the forensic team for further evaluation, because actually that for bite marks, even now, that if you bring the bite marks to the courts nowadays, that the courts is going to dismiss the bite marks evaluation and assessment, because actually that because of so many wrong assessment of the bite marks has been there. So basically that we do not want to make things worse by having another bite marks that's wrongly interpreted. All right, so they may appear only as bruising or as a pattern of abrasions or lacerations. They may be caused by other children, all right, or by adults in assault, or as an inappropriate form of punishment. All right, so sometimes that we see bite marks in sexually oriented cases. All right, so where that you can see that the bite marks happen at the neck, and then there's some breast, for example. So these are the bite marks that you will see. All right, so another thing about bite marks is that actually that because our skin is actually not a very good material to have anything imprinting on. All right, so basically that if you imprint something on the skin, so basically because our skin has the ability to heal by itself. So basically that when the healing process takes place and everything, so basically it is difficult for us to see the demarcation of the bite mark. So this is going to make the identification worse as well. All right, teeth marks that do not break the skin can disappear within 24 hours, but may persist for longer. All right, so this is actually that's something that we can see because of the healing process and so on and so forth. And in those cases where the skin is broken, the borders or edges will be apparent for several days depending on the thickness of the tissue. All right, thinner tissue retain the marks longer, and bite marks present a unique opportunity to identify the perpetrator. All right, so this is things about the bite marks. All right, so when you see a bite marks, all right, so you must first photograph it, but in a clinical setup, in a pediatric clinical setup, so I don't really expect that you get a forensic level of photography. All right, just enough that if you take photos, it has to be right angle photos with some ruler in the photos. All right, so if you do not have rulers, perhaps that you can put some coin as well, because we have to know the dimension of it, in reality. Right, in this particular sense that you have the L shape, or we call it this is not the ABF or ruler number 2, but in forensic odontology that we have the L shape, a small ruler that we call ABF or ruler number 2. So that's the requirement that we should have when we take forensic related photos. All right, so some intraoral injuries that we can see from physical abuse, bruising and laceration of the upper labial frenum is not uncommon in a young child who falls while learning to walk. All right, so however, a frenum tear is a very young in a very young non-ambulatory patient should arouse suspicion. All right, so just like I mentioned to you just now that frenum tear is not uncommon. All right, so but the thing is for children who still are not able to walk, so basically that this must be treated with suspicion. Right, it could be the case of child abuse. All right, so this injury may remain hidden unless the lip is carefully everted. All right, so when you want to treat the dental part, for example, you see the mobile teeth going on. So basically, that always make a habit to just lift the lip a bit because you wanted to see that whether there is a freedom there or not. All right, so that could lead to something else. Any accompanying facial bruising or abrasion should also be meticulously noted. All right. This is example of the frenum tear. When you lift the lip a bit, that you will see that the frenum tear in these cases. All right. So if you don't elevate it, you only see that the tooth is out of place, and perhaps you want to do a spleen and everything. So without noticing the frenum tear. All right. You will see some injury as well at the outer lip and perhaps some at the nose as well. All right, so when you see something like this, always make a habit to lift the lip. All right, so basically there are some things that mimicking the child abuse physical evidence. All right, so these are the differential diagnosis of it. All right, so if you see something bruising, for example, that impetigo may look similar to cigarette burns. All right, so this is something that you have to bear in mind as well. Birthmarks, for example, hemangiomas, Mongolian blue spots can be mistaken for bruising, and conjunctivitis can be mistaken for trauma. All right, so when you have having a red eye, so basically that, oh, you're thinking about the eye injury. All right, so you always have to relate that particular physical evidence with the story. All right. All children who are said to bruise easily and extensively should be screened for bleeding disorders. All right. So sometimes that when you see some bruising, when you ask the parents, the parents will say that, oh, my child, bruise easily. It's always like that. It's always, when they wake up, usually that they're always bruising here and there. Some, in Malay tradition we call it the jin gigit or something, So basically that's something that that the parents will say, all right. But I think that it is good that if we screen for bleeding disorders, to look into for discussions and everything. All right, unexplained multiple or frequent fractures may rarely be due to osteogenesis imperfecta. All right, so we have to look into the family history, the blue sclera, and signs of the eye if it's pertinent to the case. All right, so and then we are going into the how we want to respond this, how we want to respond to these child abuse cases. All right, so of course the features of concern that we have to look into the history and examination. All right, so a delay in the presentation, a delay in bringing the child to the dental clinic, so it's going to arouse some inquiries as well. That is a red flag. Right, so because actually that for any normal parents or caretakers, when they see something happen to the teeth, so they are going to bring the child to the dentist office immediately. All right, but a delay in that, so basically that it has to raise some eyebrows. All right, discrepancies between the history and examination of findings. All right, you have to relate the history, whether it's tally with the examination findings, and whether it's developmentally inappropriate findings. So whether it fit with the age of the child or if it does not fit with the age of child. All right. So this is something that whether that the bruising is actually happened for non-ambulatory child, for example. All right. So that does not fit the age of the child. Okay. And previous concern about the child or siblings. All right. So there could be some history or medical history about the child or other siblings, that has happened the same thing. So basically that this could, give the features of concern. All right, so now the question to ask yourself that, okay, so this is something that perhaps that, in clinics that perhaps you can, when you want to do a history and examination, perhaps this is something that you can include as well, all right? So whether you want to ask that, Has there been a delay in seeking dental advice for which there is no satisfactory explanation? All right, whether yes or no. All right, so this is something that you have to, question that you have to ask yourself, and you have to take it accordingly. All right, does the history change over time or not explain the injury or illness? When you examine the child, do they have any injuries that cannot be explained? All right, so some sentinel injuries, for example. All right, and are you concerned about the child's behavior and interaction with their parent or carer? All right, so sometimes that the children may come to you, but looking very distant with their caretakers or parents. All right, so they do not talk. Just that the parents come and then just watching the handphones and everything. So basically, that these are the kind of body language that you can observe. All right, so if the answer to any of these questions is yes, you should discuss with the senior colleague and follow local child protection procedures. All right, so basically that I think that we have a SOP for the child protection procedures in Malaysia, or at least in KKM. All right, so if all the answers are no, then diagnose and treat as normal. All right, so perhaps that we can incorporate these questions during the history and examination. All right, so I think that this is actually that the most important part is actually that sometimes that we forget to talk to the child. All right, sometimes that we are just so busy, perhaps that it is we understand that sometimes our work requires a lot of exercise, a lot of things to do. So basically, sometimes we forget to talk to the individual. So basically, that in this particular sense, that if we want to know that whether it's really a child abuse or not, that we have to talk to the child personally. All right. So without the intervention from the parents, because actually, that in this particular way, that the child is going to to reach us and then to tell you that what is actually happening. Okay, but of course that when you want to talk to the child, then you have to develop a rapport, a good rapport with the child and things. So basically, I think that one session may be not enough. Maybe that you have to spend like 2 or 3 sessions with the child, so that the children is going to open up to you and then tell you what is actually happening. All right, so some forensic aspects on these particular issues. All right, so of course that when we see some bite marks, when we see bruising, the first instinct that we want to do is actually we want to take photos. All right, so basically you can take photos, okay, but you have to make sure that the ruler is there. All right, so and then it has to be right angle. All right, perpendicular to the side. Right? You should consider whether your notes should include the diagram of your findings or be supplemented by clinical photographs. The photograph should be clearly labeled with the child's identity, marked with the date and time, referred to in clinical notes, of course, and annotated with descriptions and measurements of any injuries. All right. So basically that, we don't really, expect you to take photographs of forensic quality, all right? Because actually in forensic photograph that we have to, a rigid right angle measuring scale that we have to put in, and then sometimes we have some illumination, some special lighting as well. All right, so especially for bite marks, so we have to look into that. But we don't expect that from the pediatric dentistry fraternity, because that really takes some time to do it. All right, and then DNA sampling. All right, so where a child has been assaulted, it may be possible to obtain forensic evidence, including DNA sampling. For example, like for bite marks as well, that we are going to get some a swab, for example. All right, and then the strict procedures must be followed in order to ensure the validity in court or any samples. All right, for example, a clear documented change of evidence. All right, for example, like if you are going to take a swab, a double swab for bite marks, for example, so you have to log everything, that who is the one who is the operator, and who is the one who's going to carry the samples to the lab and everything. So because this is actually a change of evidence, because this will be asked in court. All right, so if you are having some weak link or bad link during the chain of evidence, is going to be thrown away from the court. The court is going to dismiss that. particular evidence. All right, so this is actually important. All right, so now the thing that I want to tell you actually that how to do a double swap on bite mark. All right, because usually that if you have a bite mark cases, for example, especially a fresh one, so I think that yeah, the frontliners or the dentists or the special or the pediatric dentistry specialists can do double swap on your own, because actually that we wanted to preserve the freshness of that particular bite marks. All right. So I think that you can do the double swap bite marks, but if you want to do it, you have to do it accordingly, and then you have to follow the chain of evidence. All right. So the double swap technique was developed by Dr. David Sweet. All right. So basically that he is my mahaguru in forensic, and he's the one who come up with the double swap technique. Actually, it's quite easy. All right. So you first one that of course in the bottle is actually that that's the distilled water, all right, because you have to use distilled water because you have to wet the cotton buds, all right, the swabs, all right. So you cannot use the tap water because tap water has chlorine and everything, so it's going to interfere with the DNA genomic typing later on. All right, and then after that, then you must have two swabs or the cotton buds, all right, the two swabs, all right. So the first one for the wet and second one for the dry. All right, and after that, you just immerse the first swab into the distilled water. All right, so just let it be within 10 seconds, and after that, take it out and then roll it over the bite marks. All right, so you have to roll it over. All right, so you have to look into the demarcation, the line of the bite marks, because actually you do not want to go beyond that, because if you go beyond that, that there might be a possibility that you are going to take some other people's DNA. So we do not want to have that. All right. So just bear in mind that this is only for fresh cases. All right. Because actually for fresh cases, which means that the individual or the child still hasn't washed the particular area. All right. So worst case that if they put iodine and everything, so we don't want that. Okay. And after that, after you have the wet swab, you are going to use a second swab. All right, so you are going to do the same maneuver. You are going to roll it over the bite marks, okay, in a circular motions, and then you are going to dry that particular bite marks. All right, and you have to be careful that not to extend that to the outer places, all right, because actually that yeah, you might get some other DNA for that. And then after that, yeah, you're going to have two swabs here, all right, and then you have to air dry it. Air dry it for example for 1 minute, all right, and after that you put it into packages, all right, and then you are going to have the sample sent to the lab, all right. But you have to make sure that the swab is actually air dry, all right. So you cannot use a hair blower or some, you know, if you blow it with your mouth. So that's something that it's a no-no, all right, because it's going to, you know, give some other DNAs, you know, for that swab. All right, and after that, then you put it in there, because this is actually that something that the box has been devised by Dr. Sweet. So basically, that you can, you know, put it all in a box and something like that. And after that, you know, you are going to box it and then send to the lab. All right, so I think that this is something that you know, if you are dealing with a fresh case of bite marks, you can do this double swab. You know, because actually, that if you want to call a forensic team, it's going to take some time. All right, so we have to do quickly in this particular setting. All right, so this is actually the bite marks that that I did during my masters. All right, so actually that if you see the bite marks here, actually the bite marks has you know, a lot of bite marks. All right, and then to make it worse, actually it's an overlap of bite marks. So when you want to try to work on this, you have to be careful, and you know, my suggestion that please don't do it, because actually it is very difficult. Even for us in forensic odontologists, this is actually a very difficult case to work on, because actually that the overlapping bite marks, it could be from one individual, it could be from multiple individuals or perpetrators, right? So this is actually a very, very difficult case to work on. All right, so documenting. All right, so this is actually some of the documenting, interpreting the significance of bite marks. All right, so it has to be carried out by someone with training and experience in forensic odontology. All right. So actually, that it may be also possible to match the impressions left with the dentition of suspected perpetrator. All right. So this is actually the bite marks that are going to be done by forensic odontology. Right? Dental practitioners should be clear about their own limitations and only offer opinions within their level of expertise. All right. Local police may have a preferred expert. All right. So, or perhaps that you can call the Malaysian Forensic Odontology Society, to supply some to give you advice and to undertake such work. All right. So basically, that's something that we can help you with. All right, reorganizing. All right, lastly, that this is actually the tips for the best practice. All right, so I'm not sure that whether that we have the SOP at this particular moment. All right, but we have to identify a family, a member or staff to take the lead on child protection. And secondly, adopt a child protection policy, work out the step-by-step guide of what to do if you have concerns, and follow best practice in record keeping. Right? When you want to make record keeping, for example, like photograph, for example, like some other things. So basically, follow the best practice of it, and undertake regular team training. All right. So the team has to be trained, because when we want to make this smooth. All right. So basically, that the team members has to be trained. They need to know their role. They need to know what they should do when they see cases like this. All right, and practice a safe staff recruitment. All right, so in other words, that when you want to recruit another additional staff and everything, so you have to practice a safe staff recruitment. Well, I guess that's all from me. Thank you so much. All right. So if you have any concern about the forensic advice or referral, then you can email me at fo.dentaluitm. At gmail.com, and then we can have some discussion, or perhaps I can advise you on some things, what to do, if you are, or if you are in KKM, then perhaps that you can, just contact the KKM forensic odontology team to help you with the case. All right. Well, I guess that's all. And then, this is a promotional videos or promotional flyers for the next MAPD webinar series. It's going to be by Dr. Rohaida Abdul Halim, our very own senior lecturers in pediatric dentistry of UiTM, with the title Caries Management by Risk Assessment and Preventive Therapy. All right. With that, I give back the floor to you, Dr. Faisal. And if you have any questions, I'm happy to answer. Thank you.
Right. Thank you, Dr. Yusmi Aidil. I think we are quite running out of time, but there's a few questions here. One, if I can read, I just maybe read one or two questions. Is parents' negligence in taking care of their child's oral health considered as a form of abuse?
Well, thank you for that questions. Well, negligence is, although that, we can discuss it in the same platform as abuse, but the thing is, in my opinion, that, that could actually considered as a neglect from their parents as well. Because actually in Malaysia, that we don't really have that SOP yet, but in Western, that I've seen that some literature saying that, actually that if the dentist see any rampant caries, for example, for a child, so basically they have the right to report it to the social service and everything, right? But I'm not sure that, but in Malaysia it's difficult to do it, because actually that the authority does not really see that the dental caries and everything as something that's really disturbing or something. So basically that and then another thing, that if we want to refer them to the social service, well, I think that social service may have their hands full with other cases like rape and everything. So basically that it is difficult to do it, but it's not impossible to do it. Well, I think that we should go for this fight.
All right. Thank you. One more question. If we work at a place where there is no forensic odontologist available, for example, what other record should we take for bite marks beside from pictures and swab? Like we suggest impression.
Impressions. If it is a fresh case, basically that if you see any indentation, well, you can try to do it. All right, but the thing is, in terms of impression techniques, it's very, very different with the impression that we do on the daily practice as a clinical practice, right? So I think that in terms of impression, I don't think that you should perform it, all right? So I think that perhaps that you can get the photos first, and then trying to do the swab, all right? And the rest, I think that you have to, call a forensic team for that.
All right, thank you. I have one personal question. I know it's already past 2. Just one last question, Dr. Yus. You mentioned just now regarding talking to the child. To what extent does history from children actually valid or credential in your opinion?
All right. Well, that's a good question. Dr. Faisal. Basically, that it's not that something that, when we talk to the child, for example, like the child, less than 5 years old, for example, right? Because kids say the nandest thing, right? But the thing is, it is when we ask them, it's not that something that we really ask them, okay, who did this? Who did that? Okay, can you tell me how this happened? Because this is actually not the language, not to the level of not to their level yet, right? So basically that in other way that you can always say that, okay, in pediatric language, all right? So, okay, can you tell me that, okay, who played with you? All right, for example, and then, okay, can you tell me who is your friend at school? Okay, who is the most, the most, the one that you don't really like, for example. All right, so basically from this, basically we can create a story, or perhaps as we can do some sort of like a modeling, saying that, okay, that there could be some actually people that could be the suspect in this particular case, for example, like for bite marks, for example, right? So you wanted to see that who is your friend that you don't like the most. All right, so basically that we can get that data from this particular child instead of just going, asking them like adults.
Thank you, Dr. Associate Professor Dr. Yusmi Aidil. I think we have now exceeded our 1 hour time. And with that, I would like to thank Dr. Yusmi Aidil for a very nice presentation, and also for sharing your information on especially on the mic marks. And I hope everyone can actually gain at least some information on this, particularly on managing a pediatric patient. Now, we have actually give the link to the CPD points in the comment section, right? And in fact, there's also email to Dr. Ismail if you have any further queries. With that, kindly please click on the form to get your information, your CPD points. And with that, I would like to end our webinar today. And thank you for joining us. I hope we hope to see you again in 2 weeks' time for Dr. Rohaida's webinar. And with that, thank you and have a nice day. Thank you.
All right. Thank you.